All right. Hello, everybody. Thank you for joining. My name is Andrew Oblos. I'm a hospital payment reform analyst for the Department of Healthcare Policy and Financing, and this is our second stakeholder meeting regarding the Enhanced Ambulatory Patient Grouping System, or EAPG's, implementation. In March 2014, the department announced that it would be transitioning its outpatient hospital payment methodology from a percentage charge system to the EAPG-based system. We as the department have worked closely with Public Consulting Group, also known as PCG, and 3M to make this transition. The department's objective of this meeting is to continue providing the Colorado hospital community a transparent EAPG implementation process. The department will provide updates to general policy decisions, present EAPG weight and rate development policies, walk through the methodologies of the EAPG weight and rate development, and outline milestones achieved. This public meeting also provides an opportunity for the Colorado hospital community to ask questions or provide feedback pertaining to the implementation of EAPGs. Adam Johnson of PCG will be presenting the overviews of the rate and weight setting methodologies, as well as provide the overview of our policy decisions. Anna Lukacs, who is one of the department benefits managers, and myself will be supplementing this discussion and will assist in answering any questions that may come up. We'll also be monitoring the chat in our WebEx room to make sure that we can address any questions that may come up. And I'd like to remind everybody that we'll be muting the line in order to ensure optimal clarity for our recording and request that all attendees hold off on their questions until the appropriate time in the presentation when we'll open up the floor for everybody's participation. And with that, I will hand over the presentation to Adam. Thank you.
Thanks, Andrew. As Andrew said, my name is Adam Johnson. I work for PCG, and I'll be kind of walking through this PowerPoint as we talk about weight and rate setting and some policy decisions. So I was just going to stand here. Can everybody still hear me on the phone? You could just send an IM and let us know. So the agenda for today, we're going to talk about some definitions and then get an update on the milestones that we handed out last time, and we'll be talking about EAPG weight and rate decisions and methodology. We'll have a little introduction to that too, just to kind of get your feet wet before we get into it. And we have a few handouts along with the weight and rate setting decisions and methodologies. And then we'll be reviewing the policy decisions document that was sent out at the last meeting. There's been a few updates to that, so we'll be talking about that, but mostly it's the same, and we just want to start addressing any of the questions that you have from reviewing it from the last stakeholder meeting. And then we'll be opening up for public comment after that. And the way that we're going to have it, this meeting structured, like Andrew was saying, we're going to kind of go through the weight and rate setting decisions and methodology, and I'm just going to go through all of that. And if you could just kind of take note of any questions you have as we go through, and we're done with that, then I'll take time for some questions, and then we'll go through the policy decisions document, and that'll be more of a kind of an open forum format where you can kind of ask your questions at any time. Is everybody able to hear? Yep. Okay, excellent. All right, go ahead, next slide. All right, so just a few terms and abbreviations that you're going to see in the presentation. We just want to walk through those really quickly. So the first is rate year 2017. We're referring to it as a rate year because it isn't the entire fiscal year. It's beginning with the implementation of EAPGs on November 1st of 2016, and it's ending on June 30th of 2017. So that's what we mean when we talk about the rate year. The next is state fiscal year, which you're probably familiar with, going from July 1st through June 30th of every year, abbreviated as SFY. And the fiscal year, when we refer to that, it's mostly with respect to Medicare cost reports. So those date ranges can vary from hospital to hospital, but most of the basis that we have is for 2014. So depending on when the hospital range is, that's what we're referring to when we just say FY. So just a milestones update from the document we sent out. We handed out again this time. We're on a second stakeholder meeting. We'll be reviewing policy decisions. The next two items we have on the list is tentative. We don't have a date quite yet, but another stakeholder meeting just as an update. Any follow-up questions you might have, we'll be addressing those sorts of things. And as time comes on, we'll get that date pinned down for you. This isn't all the ones that we have on the handout, but just the next couple big ones.
I just got a text from somebody at my facility that 877-688-4493 number is not working.
Oh, okay. Do they have Andrew's email? I don't know if they have, because there was like, I think, one other person that he had to send it out to. Someone on the phone, someone was having trouble calling in, so we're just actually getting the
would you be able to repeat the phone number?
877-688-4493.
Oh, geez. Okay. So the number should be 1-877-688-4493. 668-4493.
The number should be, oh, sorry.
Oh, absolutely. 1-877-668-4493.
If they, an access code? Yeah. Do you want to read that off too?
Absolutely. The access code, and I can repeat this if necessary, 797-941-540.
And if you sign into the WebEx link and you go to the meeting info, it should have that information in there as well, the call-in number and the access code. Yeah, let us know if anyone else is having difficulty with that. Thanks for letting us know. Okay, so back to the milestone. The next big milestone we have is in August of 2016, where we'll be beginning provider trainings, talking about EAPGs, billing any sorts of billing changes, and how EAPG is going to really work into the nitty-gritty of that. And then in November of 2016 is EAPG will go live November 1st of that year, or dates of service on or after November 1st.
Yep, I'm going.
And then just as a little introduction to the weight and rates, because I don't think we've really gotten into it too much into detail from the last meeting. We mostly talked about ways that you can modify the weight, but just wanted to get feet wet before we get into it. It'll make more sense when we get into methodology as well. But there are two components to EAPG reimbursement. There's the EAPG weight, and there's the provider base rate. And the weight is something that's assigned to every line item of the claim, and it's based off of the procedure code billed on that particular line item. And basically, the weight is a number that designates the intensity of the particular service on that line item. And then that weight is multiplied by the provider's base rate, and that's where you develop the particular line item payment for that particular line item. So just to get a little introduction, and we'll get into the weight setting decisions now. So just listing them out. For the most part, the weight set that we will be calculating will be state specific. So we'll be using only Colorado claims data to set all of the weights for EAPGs. A lot of the times, you'll still end up with some EAPGs that have somewhat of a low volume, and so that we maintain accuracy instead of dealing with a low sample size. We'll default those to the national weight set, and that's something that 3M put together using national data, and we'll use those national weights in place of that if we don't have enough to do a state specific. For grouper version, we'll be using the version 3.10, which was released in January of this year, 2015. For setting weights, we'll be using 3 years of fee-for-service data, fee-for-service outpatient claims data. Those fiscal years are 2014, based on dates of service. There are a few exceptions to what we'll be setting for EAPG. For the most part, we'll be setting weights for all EAPGs, and there's a few exceptions. One is the inpatient-only EAPG, because that one isn't covered on an outpatient setting, and then also any uncategorized EAPGs. So next, we just got another few decisions. When we talk about calculating the costs for the hospitals, we'll get into more of that in the methodology, but we use the Medicare cost report, the 255210, and specifically fiscal year 2014. Based off of we use the electronic database that CMS put together called the HCRIS. You can see it's the Healthcare Cost Report Information System, and we compile that data to calculate costs for the hospitals. Another decision is only to use singleton claims for the weight setting. This is a reference to only having one significant procedure on the claim. And this is relevant because Dave talked about in the last meeting things like packaging and consolidation. And specifically packaging, in those sorts of situations, what's going on is you've got like an ancillary service billed with a major surgery. Those ancillary costs are covered in the payment made to the surgery. So those ancillaries are packaged. They're paid zero. But the idea is that they're covered in the cost of the surgery. So the issue with weight setting comes in where you've got, if you have two different significant procedures on the claim, and you've got an ancillary that gets packaged, there's no, the grouper doesn't link the package detail to a specific significant procedure. So when we're pulling up the cost and putting it into the significant procedure, we don't know which one it goes into or if it's split between the two. So just to make sure that we're getting an accurate cost for just the one surgery, we only deal with cases where there's one significant procedure. So that's the reason for that. As we talked about earlier, most of the EAPGs will receive weights. An exception to that is EAPG 999, which is basically it's the unassigned EAPG code. And in that case, the weight will be set to zero, but when we're calculating the weight, all of the costs associated with any line item that's 999 will be distributed in the remaining line items that will have weight set for them. So even though on your claim the 999 is going to have a payment of zero, the costs for that 999 are being covered and paid for in the remaining line items. And then that also goes for DME and dialysis EAPGs. Those will also be set to zero, but the costs will be distributed just like 999. So now, moving more into the methodology for weight setting, the first step in setting Colorado-specific weights is, like I mentioned earlier, we take those 3 years of claims data, 2012 through 2014, and we're going to process them through the EAPG grouper version 3.10. And the reason for that is to assign an EAPG to each of the line items so that we can start associating the charges on those claims to a particular EAPG. And then we crosswalk those line items on all those claims to a particular cost center, Medicare cost center, based on the revenue code billed on the line item. We use a CMS revenue code to cost center crosswalk for that. And then tabling that for a minute, then we go to the Medicare cost report and we pull the data to calculate the cost to charge ratios per each hospital, per each cost center. And then we bring that back to the claims data, which has now been associated with the cost center, and we match up those CCRs with the appropriate cost center and the appropriate hospital and convert the charges on the line items to costs. And the last step with calculating the cost for the EAPGs is standardizing the data for any sorts of differences that there might be from hospital to hospital. Because basically what we're trying to do is we're trying to get to, for Colorado, what is the cost of this particular service, aside from any other influences on the cost that there might be. Moving on to the next slide. The next step is removing so we eliminate all of the non-singleton claims, as I mentioned in the decision. On top of that, we also remove any outliers that exceed a certain multiple of standard deviations from the average for that particular EAPG, and we set that to 3 standard deviations. So any particular claim that for that EAPG, the cost is way beyond 3 standard deviations of the average for that EAPG, then we cut that out so that we're not skewing the average cost inappropriately, but we're focusing in on the true cost of that service. And then from there, we actually calculate the weight itself, and the calculation is right there. It's the average cost of that particular EAPG over the average cost of all EAPGs. So the basic intention of the weight is that it's all relative to the other ones. So every weight is relative to the rest of them in intensity. One's going to be more intense than the other. And this is the calculation for that. The only other things that we do after that, we do modify the weights a little bit more just to make them as accurate as possible. And the first thing is we weight scale to reconcile between the state-specific weights and the national weights. If you remember from the decisions, we talk about most of them are going to be state-specific weights, but we do, if there's not enough of a volume of line items for that, we default to the national weight. And both of those weight sets are in slightly different levels from each other, so we scale the state-specific to the national to kind of bring those together so they're on the same page. And then the last thing we do is we reorder some of the weights, because sometimes what will happen, you've got a particular service like skin repair, and you'll have 4 different EAPGs for that, level 1, level 2, level 3, level 4, each one increasing in intensity. And sometimes when you do the state-specific weights, you don't get a very even progression of intensity from one level to the next. So we will sum up those state-specific weights for those 4 EAPGs and redistribute the weight based off of the national weight distribution from one level to the next. So it's still state-specific, but we're just evening out the distribution according to the national weight set, which has more data, so that's why we're kind of using it as a base. And then, so we'll be going to a handout.
Do you want me to?
This will be handout 1. Yeah, if you could just switch, you should be able to. I might have to exit out of the slideshow. Just hit escape. And now we'll be looking at handout 1. So hopefully this will help just show you how this methodology works. And we use a specific claim.
Make it all that go away.
Yeah, if you go up to the top, just click each of the blues. It'll make them. Or just okay. So yeah, we're looking at handout 1. We start at the claim level, but obviously it'll go out because we use all the claims. But looking at a specific one, we've got date of payment on July 2nd of 2012, and the EAPG assigned to the particular line item that we're looking at is 658, which is lumbar disc disease with sciatica. And when we convert the charges on that line item to cost, and we normalize the data like I talked about, we get the line item cost for that EAPG being $126.06 for that particular claim on that particular line item. The next step is we find out what the average is for that particular EAPG across all of the claims and line items that we have for that EAPG. And we see that that average cost is $221.57. And we're calculating the standard deviation for that at 189. And then we create our upper and lower bounds, 3 standard deviations from the mean. So the upper bound in this case would be $789, and the lower bound would be $0 because you can't get any lower than that. And so then we pass our line item costs from number 1 into that bound, and obviously it fits it. It's not the mean, but it fits within that standard that we've set for the 3 standard deviations. So we accept this claim as one that will be used in the calculation of the weight for this particular EAPG. And once you go through all the claims data, and you've rejected some, you've accepted some, and in this case we had a total count of accepted EAPGs being 2,134, and total cost for all those accepted EAPGs being $445 million. And when we divide that in to get the average cost per EAPG, we see that it comes out to $208.75. So a little bit different than the average before we rejected the outliers. Now we're really focusing in on the true service of that particular EAPG, the true intensity of that particular service. And then we've got we plug in the average cost of all EAPGs, and that's after you've excluded all the outliers in those cases too. And you just divide that 208 by the 342, and then you get a weight of 0.06 or 0.6098 for this particular EAPG. Yeah, so that's basically the methodology for that. Could you go back for just a second? Yeah. Okay. Yep. Go ahead back to the PowerPoint. Now we'll talk about rate setting. We'll talk about the rate setting decisions, and then we'll go into the methodology as well.
Can we get back to that? Can you get it back to that presentation?
That's it right there. So not quite as many decisions for this, but there are a few. Just to reiterate the definition of an EAPG rate, get a little bit more into that. We'll get into that with the methodology. It'll make, we'll understand that. So as far as the decisions that were made, for rate year 2017, there will be a corridor mechanism applied to limit the disruption of expected impacts to providers as a result of switching to EAPG method. So this is basically, we'll get into the calculation a little bit with the actual handout too when I walk through that example, but it's trying to prevent any sort of wild difference between reimbursement in EAPG versus what you currently get with the percentage charge, because there's obviously a lot of big changes, now that we're using procedure codes, and they weren't ever required before, so there's going to be a lot of transition time needed and kind of a little learning curve. So this is to kind of help with that by not allowing the difference in payment being more than the corridor. Another thing that we do is, so due to the effect of Medicaid expansion in fiscal year 2014, we are calculating kind of a trend factor based on the years before that, and now using this new updated utilization in 2014, we're projecting out what's the utilization going to be in 2017 for when we're setting these rates. And we'll talk about how that gets incorporated into the process in the handout as well. And then the last thing that we have to talk about with regards to decisions with base rate setting is the fact that I kind of alluded to, where currently there's no requirement for procedure codes in every line item, and recognizing that, and that now, to get reimbursement, you got to have a procedure code, otherwise you can get 999, which will be paid at zero. And if you don't have any line items with payments on them, then you won't get any payment for that particular line item. Recognizing that that's probably going to change now, we're going to get more procedure codes. We're expecting there to be an increase in the total number of procedure codes billed, and we're going to try to account for that when we're setting rates based off of the number of details currently being billed without procedure codes. That's basically the idea behind that projection. So walking through the methodology for setting the base rate, just to start off with what exactly an EAPG rate is. It represents the average payment per adjusted weight the providers will be paid. So this is the rate is modified by the weight, so you're multiplying it to get that payment on the line item like I talked about before. And it does say adjusted weight. I want to make a note of that because I'll talk about it in the handout, what exactly I mean by that. But we'll get into that on the handout. So walking through the methodology really quickly, the first thing we do is we take those weights that we established in the first section, and we run those claims of fiscal year 2014. We only do one fiscal year because we only need one to mirror 1 year. So we're taking that 1 year and using it for 2017. And we run that 2014 claims through the grouper with those weights. Now we're associating the EAPG to the line, but we're also putting a weight on it. And then the next step after that is we modify those weights that have been added to the claims. We modify them by that trend factor I was talking about. So now we're accounting for the extra utilization that'll be occurring between 2014 and 2017 to project out how much more there's going to be than there was in 2014. And then we aggregate all those EAPG weights for all hospitals, so we get a total count of all the weights for all the hospitals, and that gets divided into the projected spend. So we take the projected spend divided by that weight, and then we get a statewide base rate. So like we were talking about in the beginning, the EAPG rate represents the average payment per adjusted weight. So we take those adjusted weights, sum them all up for all the claims in all the hospitals, and we divide that into the projected spend for that particular year, so then we get the average payment per weight, and then that ends up being your statewide base rate. We'll do that process in handout number 2. Similar to the way we did it with the weight setting, but so we're just going to work with that same EAPG. We're going to do a different claim because obviously that was an older claim. It was in 2014. But we're going to go with that EAPG 658 lumbar disc disease of sciatica. So we start off with that full weight. Like I talked about, we send the claims through, get that weight on the line item. In this case, it's going to be that 0.6098. And then this is the part that I was talking about, the adjusted weight. So the payment percent is something that modifies the weight of a particular EAPG on that line item. And if you could just go down to the considerations number 1. Scroll down a little bit. So there's a little superscript 1. So on the bottom, this line payment percent is 100%. So the adjusted weight is going to be equal to the full weight. And what that really means is that there was no consolidation, packaging, or discounting applied to this line item. And as Dave Fee talked about in the last meeting, packaging and discounting, these are all things that, either with packaging you're paying 0 on that line item, with discounting, you might be paid at 50% of it. This is where all that comes in. It comes into that with that payment percent. And we take that adjusted weight, and that's what we use to make the payment, and then also is what we aggregate to come up with the statewide base rate. So going back to that methodology then in our example here, so we got the adjusted weight, and then we have our calculated trend factor weight, which we use 3 years of claims data to project out what that trend factor is going to be, and multiply that by that adjusted weight, and we get our trended adjusted weight. So now we're at the point where this is going to be the weight of 2017. So it's no longer the 2014. It's the trended 2017 weight for this particular claim. And then we aggregate first by hospital so that we get our total adjusted weights by hospital. And then after that, we aggregate by all the hospitals to get our total weight across the whole state for that year for all hospitals and all claims. And dividing the projected spend by that total weight, we get our statewide base rate, in this case 255. And just for the record, I have it noted in the bottom, these are just purely example numbers. These aren't the real numbers to be represented in 2017, just to to kind of show you the process here. And that goes for the other one too, I forgot to mention it. But so then we get our statewide base rate, which I talked about, so that's going to be the calculated average payment per weight. And normally that's where it's going to stop. But as I mentioned, for that first rate year, 2017, there's going to be a corridor placed in to prevent any sort of drastic change in payment for any particular hospital. And on number 4 there, it explains, so the corridor mechanism ensures that total provider payments through EAPGs, given a projected utilization, will fall within a predetermined range. In this case, it'll be set to 10% of what the provider would have gotten paid through the current reimbursement method. So what's important here is this transition percent of 10% isn't really a reference to the base rate. It's not, going up or down in that. It's a reference to the payments that would be made, and that the payments for that particular hospital wouldn't be greater or less than 10% of what it would have been under the current methodology of percentage charge. So no matter what it would be under EAPG with what we've projected, we don't allow it to go above or below 10% from what it would have been under the current methodology. And so to achieve that, in this case, the transition corridor adjustment would be $29, just as an example. So then the corridor base rate for this particular hospital A is $285. So this first rate year, each of the hospitals will probably get their own unique base rate based off of this corridor. But moving forward, it's going to be, everyone's going to share that same statewide base rate. And then the determination of differences in payments is based off of the weights that are for each hospital. So each hospital has an aggregated weight that'll determine the intensity of services for the hospital for the whole year, which will be the basis for payment then. Okay, moving back to the PowerPoint. So that's kind of running through all the rates and weight setting decisions and methodologies. At this point, we'll be moving to handout number 3 with policy decisions, but I also wanted to open it up for any questions so far that anyone's had. For anyone on the phone, if you could just send an IM through the chat if you have any questions, and then we'll address that. Are there any questions to start off with right now? Yeah, go ahead. It's kind of a. Can you repeat the question? Oh, sorry. Yes. The question was about when I referred to EAPGs that were inpatient only and uncategorized, that they wouldn't receive weights. And the question was, what is an uncategorized EAPG? And that's basically like a 999. So that's 999 being something where the procedure code just does not have it doesn't have EAPG assigned for it. And most of the time you get 999 when there's no procedure code. So basically, an uncategorized EAPG is an instance where there's no procedure code billed on the line item. So if there's no procedure code, then we can't get an EAPG. And so it defaults to 999, and then is paid 0 because we don't have a weight for that. Does that make sense? Any other initial questions? Anything on the phone? Okay. Yeah, if you've got anything, just go ahead and raise your hand or anything. Oh, yeah, go ahead.
Is the transition corridor just that non-current payment, or is that paid down to the duration of the?
That will, Andrew might be able to address that better, but
for the purpose of the transition, yes, we will have the 10% corridor. That is only temporary. We do plan on eventually releasing that corridor and working around that. So we're just doing that to mitigate the effects of the transition.
Anything else for now? Okay. Start going through that policy decisions document then that we had sent out last time. I'll kind of walk through each of them, and if anyone has any questions on the phone or anything, just go ahead and raise your hand, and I'll make sure to keep looking at that answer. So first policy decision is referring to the particular claims that are going to be sent through the grouper, and it's basically going to be any hospital that that bills outpatient claims. The EAPG grouper is an outpatient claim reimbursement methodology, so the limitation is anybody who bills an outpatient claim. This excludes psychiatric hospitals. Next decision refers to the definition of an episode. So the grouper uses episodes or visits, you can call it a couple different ways, to kind of organize claims, because it recognizes that occasionally you're going to have more than one visit on the same claim for different dates, and it automatically, in this case, each calendar day is going to be defined as a particular visit, and the exception to that is for any ER or observation visits designated by the revenue codes to account for things like spanning multiple days. Obviously, observation is going to span multiple days, and in an ER visit that comes in late at night and stays through midnight, you're going to have 2 dates, but we'll recognize that it's an ER, it's just going to be one visit, so it'll be designated as one visit even though there's 2 dates. And those are basically exceptions to that. Does that make sense? Next one is a reference we've talked about a couple of times, procedure code requirement. From now on, starting with the implementation of EAPGs, the procedure code will be required in order to be paid, because that's how we associate an EAPG. Then you get your weight, and then you get your payment based off that weight. Laboratory services and therapy services are kind of in the same category. They will be sent through the grouper for payment. There are some decisions still tentative at this point how we're exactly going to be doing that, because further updates will be probably in the next meeting. We'll be talking more about those services, but for now they'll be processed through the grouper. DME services. So I talked about that in the weights and how those will be set to 0, and the reason behind that being that DME services shouldn't be billed on outpatient claims, and therefore they're not going to be paid on them if they're billed as outpatient. Instead, they should be being billed as professional on the 1500 claim form. Could you just scroll up a little bit?
Scroll down there.
Or scroll down so that it moves up a little bit, so it's not at the bottom. Next one is with regards to pharmacy and drug services. So those services will also be sent through the grouper. There are still some tentative decisions being made about, just like with lab services, we haven't gotten all the ducks in a row yet, so there'll probably be more updates on that coming in the future, especially at the next meeting. But at this point, they're definitely going to be processed through the grouper. Emergency room visits and outpatient visits, or observation visits, we had kind of talked about that already. Those will also be processed through the grouper. The way that the grouper handles them, it really zeroes in on what types of services, the intensity of that particular ER visit based on the diagnosis code, and that goes the same for observation. Dave, I think, talked about that in the meeting, the first stakeholder meeting we had a little bit. But those will be processed through the grouper as well. Next decision relates to dual eligible beneficiaries. So Medicare, Medicaid, both the Medicaid claims, outpatient claims will be processed, as well as the Medicare crossover claims will be sent through the grouper to do reimbursement. Page. So the next decisions, kind of working more from general policy decisions regarding billing, like we were talking about, moving more into the grouper option decision. So this is these are some of the things that Dave talked about, the features of the grouper, and we're going to talk about what exactly the decisions were made by the department for these things. The first topic is discounting, and you can see, based on the subtopic, all of the different types of discounting that there is and what the department will be doing for them. So the multiple significant procedure discounting will be turned on. That is a reference to having, like I talked about earlier, those non-singletons that have more than one surgery on the same claim. This is that sort of scenario where you've got more than one surgery and it's in the same visit, so the subsequent surgeries will be discounted according to this ratio here. The first will be paid at 100%, then the next at 50%, and then if there's a third, 25%, and so on and so forth, 25% for any subsequent surgeries after that. Hopefully, not too many of them that have that many surgeries, but the next type of discounting is repeat ancillary. So in the cases where you have not just more than one ancillary, but the same ancillary billed more than once, those subsequent services of that same ancillary will be discounted in the same fashion, the first at 100%, the next at 50%, and the next at 25%. And at this point, we'll also be doing repeat ancillary drug. So the same thing applies for any drug claims or any drugs that are billed on the claims. That if the same one is billed at the same time in the same visit, then the discount will be applied. Bilateral discounting is referring to bilateral procedures that the same surgery done on both arms or both legs. This is when they're billed with that modifier 50. So you just get the one line item, the modifier 50, indicating really that there were two surgeries. And so in that case, when the modifier 50 is present and it's a legitimate bilateral procedure, then the discount's 150%, kind of the same methodology as multiple significant procedure, but we're only on one line item. So we've got two services on one line item, first at 100% and the next at 50. So therefore it gets that 150% discount to account for that bilateral procedure. Next, discounting for terminator procedures. Those are indicated by certain modifiers, and the discount for that will just be 50% for any surgery or anything that's stopped halfway through. Will be a partial payment for that. Another option for significant procedure discounting, that first one, is Dave kind of talked about, there's significant procedures and there's also a breakdown of significant procedures. You've got just the general ones, but then you've also got like radiologic, other diagnostic, there's dental significant procedures. So you've got all these different categories. And generally the discounting, the significant procedure discounting only occurs within those groups. So if you've got a radiological significant procedure and you've got some sort of other diagnostic significant procedure, those won't discount against each other because they're in different categories. So they're considered separate. And there is an option to allow for those two different categories to discount against each other, but the department has decided to go with the default of having that set to no. So in those cases, there won't be a discount if they're in different categories. So they're significantly different significant procedures. Next option is consolidation, and there's two types of consolidation. Same significant procedure in clinical. In both cases, they will be used in the grouper option. So if you've got the same exact procedure, same surgery being performed multiple times, and it's in the list of codes for this consolidation, those subsequent procedures that are the same thing will be paid at zero because the increased in cost of doing multiple of that same surgery is basically negligible. It's all covered in the first one. Did you have a question? Okay. I thought you had your hand up. Sorry. Just wanted to make sure. Clinical procedure discounting, that mostly refers to things like add-on codes. So when you've got a surgery and then you've got another got something else that you kind of have to do, but it's not very significant when you compare it to the surgery, it's covered in the cost of the surgery, and so that's not paid separately. And as I talked about before, things like consolidation, when you have those sorts of situations where the idea is that the payment for those subsequent procedures is covered in the first surgery or the main surgery, that's accounted for in the weight setting by, in those circumstances, we compile up the costs for those subsequent surgeries. We put them in the cost for that main surgery. Then that weight is augmented based off of those extra ones. So the payments are being paid in that main procedure. Next topic is modifiers. So the grouper recognizes the entire modifier set, but it only does particular things with some of them. And they're listed out here. So we've got modifier 25, which indicates a distinct service, and that's defaulted to off. So most of these we left at the default, or can be turned off. So if modifier 25 is present, it's not going to have any impact on the particular line item it's billed on. Modifier 27 is referring to multiple medical visits on the same claim. So where you have two separate E&M codes on the same claim. Generally, that second medical visit gets packaged because it's, we really just view it as one visit. It doesn't recognize each of those subsequent procedures. But if it is the case that someone came, in the morning with had some surgery, and then, on the car ride home they got an accident or broke, and then had to come into the ER later that day, so it's the same member, but there are two distinct visits, you can indicate that that second one is a distinct visit by adding this modifier 27, and then that subsequent medical visit won't be packaged, and it will pay separately. Modifier 59 is an override for the consolidation feature. So as I talked about consolidation, the idea is that you've got two of the same significant procedures, the same surgery is being done more than once, subsequent one gets consolidated, but this modifier 59 will indicate those were totally separate surgeries. They weren't done at the same time, or so they should be paid separately, and then this allows them to be paid separately. We have some therapy modifier codes. Those are defaulted to off. We're going to leave those off so they won't have any influence on payments being made. The last, there might be more modifiers on the next page, but the next modifiers are anatomical and select modifiers. So this is a whole plethora of things like the LT and RT modifiers. So, in those cases, specifically LT and RT, if you've got, that same surgery being done more than once, but it's really kind of a bilateral procedure. So you've got it once on the left and once on the right. Generally, the consolidation is going to pay zero on that second one, but by having the anatomical LT and RT present on the details, those details will pay separately because they were really separate surgeries or separate items to be paid for. This is the last page. And then there are also the never event modifiers, PA, PV, and PC. So in these cases, we are leaving it the default option, which is to have it on. So basically what that means is if any of these modifiers are billed on that particular line item, the payment is automatically maybe put to zero, simply by the nature of that modifier. Modifier 57, decision for surgery, that one is defaulted to off, so that won't have any influence on billing. And then that also goes for the distinct procedure modifiers. Those are also off. So there's just about half of them that we'll be using, like I explained, and cobbles all these things together. Talking about moving back to packaging a little bit, because we had talked about that on and off, and then we'll also be referring to it in a little bit. There's an option for significant radiology packaging, and this is basically asking the question of whether or not ancillaries should or should not be packaged in radiological significant procedures. And in the case of the department, it was decided that all ancillaries billed as significant radiology procedures should be packaged into them, and they won't be paid separately. As we've talked about before, so the inpatient-only procedures, I mentioned earlier about the inpatient-only EAPG, and that one's 993, and it is referring to procedure codes that are considered to be inpatient-only, and there's a default list set up by 3M, and that default list was reviewed by the department, and that will be used to define what an inpatient-only procedure code is.
Excuse me. Where can the hospitals obtain the inpatient-only 3M?
That should be something that I think they have availability to when they get set up with the grouper. It's some of the documentation that 3M provides. Is it in the definitions manual? Yeah. So there's a big document that goes through all the APGs. It's one of the appendices in there. So yeah. Next are dialysis codes. So we just have a couple never pay EAPGs. I had mentioned those in the weight setting, that those EAPGs would be set to 0. But in addition to that, they're also being set in the grouper options to be never pay. It's basically doing the same thing. Whenever a dialysis code is being billed, it automatically goes to 999 and pays 0. For packaging, it's kind of similar with patient only. There's a default list of EAPGs that package in the presence of significant procedures. And the only exception we're making for that is the 449. And the 449 is significant because it's referring to that Modifier 27 I talked about. So when you have more than one E&M code on the same visit, they're considered to be distinct by that Modifier 27. What happens is that Modifier 27 line item gets assigned a 449, which generally packages, but because we're using 27, we're going to pull that 449 out so it doesn't pay separately. And again, with the inpatient-only default list, that packaging list is also present in the definitions manual as one of these. And the last decision on this list was regarding the 340B drug policy. So we will be using the UD modifier to identify any of those 340B line items. Yeah.
You will be required to provide the UD modifier on there?
For any of those 340B drugs, yeah. Yeah.
It says page 4 of 8. You mentioned that's the last page. So were there really just 4 pages to this document? Or
Yeah, there are 4 pages.
Okay.
There's another,
So typo.
yeah.
Yeah. Sorry about that. Sorry about the confusion. Yeah. So any questions on anything we talked about, or anything that anyone wanted to ask about the policy decisions document that we gave at the last meeting? Anybody on the phone who's got anything? Okay, so we've got a question on the phone about what about the GT modifier for telehealth? Andrew, did you want to address that one?
I think that's something new that 3M added to a new version.
In version 10, you actually call out
We're going to have 310. So that was released in January.
Yep.
So that is something that
We'll have to look into it.
we'll have to look into that. When we made a lot of these decisions, it was before the release of 310. So we'll need to look at that one separately, and we'll make sure that that information, once we get that out, we'll make sure that everybody's informed of what our decision is on that one.
Any other questions? Yeah, CPT HCPF. Yep. Yep.
I have a question on that. So for 450 rev code right now, we're required to roll it up and not put it in HCPF. Are those types of things going to be changed in the manual so that way we won't get
need to be expanded out instead of being rolled up into the one revenue code.
So we're switching to a new claim system, so we're building that in the new system as well.
And those sorts of details will also be covered in the trainings that I mentioned. A few months before implementation, we'll be starting to go around doing provider training. We'll talk about all those sorts of little nitty-gritty of the billing and how billing is going to change. And that's probably the biggest one is going to be related to how procedure codes are being billed today versus what they're going to be after EAPG is implemented. Any more questions? Nothing on the phone? Okay. Well, we'll open it up for public comment. Anything anybody wants to say?
I have a question kind of around the timeline. Talked about June 2016, it sounds like some of the final rates will be available. At that point, will you be sending kind of like under APR-DRG, department sent out like a projection of here's what we project your impact is going to be in going from CMS DRGs to APR-DRGs. Are you going to be doing something similar instead?
Yes, that will be the case.
Okay. Well, if there's nothing else then, any other questions that you guys have going forward between this meeting and the next, you can go ahead and submit them to this email address on the PowerPoint here. And this PowerPoint, we'll be sending out the handouts in an email after the meeting so everyone can have access to these things, especially for the folks on the phone who weren't here. Those handouts will be sent out by email.
And in addition, I would just like to remind everybody that this meeting has been recorded, so we will try and get that posted somewhere on the BigPuff website. And once that's made available as well, we'll make sure that that link is communicated to all those who were invited. Okay. All right. And I think if there aren't any further questions then, looks like we got done a little bit early. We could give everybody back the rest of their afternoon. And thank you, everybody, for attending. And just make sure to inbox. We'll make sure all the handouts and the presentation is distributed. All right. Thank you.